is none other than Dr. Jenifer Jeba. So she is a professor and heading Department of Palliative Medicine Care Unit at Christian Medical College and Hospital, Vellore. She completed her post-graduation in radiation oncology, pursued a career in palliative medicine. She is a faculty in the Department of Palliative Medicine since 2006. She received a Commonwealth Scholarship and completed Diploma in Palliative Medicine and MSc Palliative Care Medicine from Cardiff University, UK. She was a joint recipient of the famous Dan Cecilia Saunders Medal for the top student in the Diploma in Palliative Medicine from Cardiff University in 2008. She is an honorary senior lecturer at School of Medicine, Cardiff University, UK, and also an associate editor of BMG, Supportive and Palliative Care. Welcome, ma'am. Welcome to the intermediate section of this foundation course. Over to you, Dr. Jenifer, ma'am.
Thank you, Sheila, for that kind introduction, and good evening to all. I can see at least 80 plus participants today, so it is really heartwarming to see so much of interest, and that is what will help palliative care reach many in India. So I'm just trying to share my screen. I just want to know whether it is visible. I'll put it on slideshow.
Screen is visible, ma'am. Yeah.
Screen is visible. Okay, great. Okay, am I also audible?
Yeah, you're audible.
Okay, so I hope we go without any technical glitches, but in case I am not audible or anything, any of you can just, not any of you, Sheila, or you have my number. In case there's any technical glitch, please give me a call. So thank you all for joining, and I really appreciate your interest and commitment to learn palliative care. Some of you, each of you may have come with different expectations, different understanding, prior understanding of palliative care, and why you joined this course, what you want to get out of it may be slightly different, but being the first class today, I hope I will give you a good understanding of what palliative care is. So what I want to do in the next 40 minutes or so, 45 minutes is, what is palliative care? Why palliative care is needed? The concept around serious health-related suffering. When do we consider palliative care? For whom to consider palliative care, and who can provide palliative care? So as we go through, if you have any doubts, you can keep putting it on the chat, or you can write it down so that we can take questions at the end. So I will start. There are many stories to tell about patients and their needs, but just about one 75-year-old man who was a widower. He had a pelvic malignancy, which also involved his scrotum. So he had 4 children who were married. He lived alone. His sons lived close by, and food was provided to him by one of his children. He completed cancer-directed treatment, but lived with a lot of pain, scrotal ulceration. And finally, this scrotal ulceration had a lot of maggots in it when he was first brought to when we saw him in palliative care. So just to enlist the different kind of needs or problems he had, one was pain. He had an ulcer, he had a wound which needed dressings, which had maggots. He himself felt he was a burden. He was living alone, but he felt he was a burden to his family. There was a dependence on extended family, not just for food, but now his health needs. And he was worried that as the days and months go by, this need of dependence would increase. He was also needing financial support from children and felt lonely. In addition, because of the site of the disease, he felt his dignity was compromised. He finally ended up doing things, whatever is easy for children. He gave that decision-making to his children so that he doesn't add to their burden, or they don't have to comply to his needs and desires. And he expressed a desire for hastened death and felt there was no point, no purpose in living. So if you look at the slide, I have just put different aspects of his needs in different colors. So the common things we would, as any doctor, we would pick up would be the physical symptoms. He's got, this patient has got pain, this patient has got ulcer, this patient has got bleeding, maybe foul smell. But only a much more detailed evaluation, exploring will actually tell us the ones in red are his psychological needs. You know, he's what is he feeling? What are his emotions like? The ones in purple are, you know, relating to his financial or his social needs, his economic needs. He's feeling lonely. Yes, that can be a psychological need or a social need. And the others can fall into the category of, you know, his dignity, his role, either social, spiritual, and maybe if we, I have to say, if we had some patients like this can say, what is the point in living? Why am I going through all this? What is the meaning in all this? So those would be spiritual needs. So if you look at just this one patient, you see that their palliative care needs are very much around the physical, psychological, social, spiritual, and sometimes even information needs if the patient is not brought into the discussion of what is happening to him or her and what they want going forward, or taking them into the decision making. And so in most patients, the issues, the problems, the needs are much more complex than we see. It is like that iceberg picture which I have put in the right lower corner. What if we just superficially ask, discuss, you may only see the top of the problem. Only when you dig deep, only when you go and explore further and further, will we get to know the other needs of the patients. Always think broad, always explore broad, but also go in depth to find out how it is affecting their hope, dignity, meaning, where are they in their religious or spiritual aspects as well, because all of these are quite interrelated when it comes to someone who is requiring palliative care. And that is why the needs of the entire person, the whole person care, we would say, or holistic care or person-centered care. So remember this in mind, you know, palliative care is holistic, it is person-centered. So what is palliative care? I think if I have to give a very simple definition, this is written by Robert Wycross. He's a pioneer in palliative care from UK. He passed on last year. So he defines it very simply: active, total care of patients. What do you mean by active? Sometimes when we think active care, we think of intensive care. We think of, what is the diagnosis? How do we sort out this dilemma in diagnosis or whatever? But palliative care is active and intensive in the sense there is always a question. You have to question what more can be done. What is happening with the patient? So often sometimes even with colleagues from other departments, you get a sense that okay, nothing can be done, so counsel the patient, give the patient comfortable. Even the way it is expressed sometimes looks very passive. No, it's like nothing more to be done, no hope. But no, that is not the case. It's an active care, and it is total care. Total, we talked about all the domains that actually affect the patient in those with incurable, progressive, life-threatening conditions. So I want you to see that the word cancer is not there in the definition at all. Though palliative care is more, or rather, can I say, cancer patients have more access to palliative care, or more cancer patients are referred for palliative care than other conditions. It is for all incurable, progressive, life-threatening conditions. In the first bit, we saw for patients, but also for their families, and delivered by a multi-professional team. By now, you would have understood with all the sort of needs, just a one-to-one person care, we may not be able to handle all the needs or support them in all their domains. So it is often provided by a multi-professional team. But having said that, I would say every member in the team should be able to provide some level of, a doctor should be able to provide some level of psychological care, should be able to provide some level of spiritual care, but best if you have a multi-professional team. So the next point to come to is I'm just putting down some definitions which have evolved for palliative care. But to make a point that palliative care is not synonymous to end of life care. Okay, palliative care is not equal to end of life care. WHO in 1990 defined it for patients with progressive or advanced disease with limited life expectancy, when the disease was not responsive to curative treatment. If you see the definition in 2002, it is for those with life-threatening illness to prevention and relief of suffering. In 2020, they redefined palliative care using a consensus-based definition. And here, if you see, they have taken away progressive disease, they've taken away limited life expectancy, they've taken away life-threatening illness. And it says, the words that are retained are active, holistic care, individuals across all ages with some severe illness, with serious health-related suffering. So I want you to remember the word serious health-related suffering due to severe illness, and especially those at the end of life. What it tries to do is it tries to improve the quality of life of patients, families, and their caregivers. So it is not just about the patient, it is about the caregivers as well. So what are the key components of palliative care? Starts with relationship and rapport building. You will understand that when that iceberg picture you remember, unless you actually build a relationship and develop a rapport, nobody is going to come and talk to you about their family or their spiritual distress or their psychological needs. So we start there, but also it is about addressing symptoms, addressing coping, a diagnosis, a progression, how is your emotional status helping or not helping, coping, linking up with other support systems, helping them understand the illness, make decisions, not just for cancer, for other illnesses as well. And as they progress, end of life care planning, what are their preferences, what are the values and goals that they want, where do they want to be, and engaging with family members. So it's very patient-led, family-centered, and with attention to detail and a very flexible kind of approach to care and team-based in a timely, collaborative manner. So the interprofessional team can consist of the doctors, nurses, social workers, psychologists, chaplains, or pastoral care, other support services. It can be a dietitian, physiotherapist, occupational therapist, volunteers, or speech therapists based on the needs of the patient. So when interprofessionals, different healthcare professionals who are skilled in different aspects come together, they collaborate to achieve a common goal that will help the patient and the family. The key people in the team is actually the patient and family, because they are the final decision makers in the entire care. So together we can make a difference. So that is a team goal. So we said palliative care is patient and or person-centered. I think more and more we are replacing the word patient by person. It is death accepting, but also life enhancing. So it is not promoting death. It is not weakening death. You know, I have had the people come and say, please see the patient and do something that they are not suffering long. Okay, there is a subtle thing that, you know, you do something so that they are not living long. So it is not death quickening, you know, you're not hastening death, but death accepting, life enhancing, a partnership between patients and carers. We are concerned with the whole person healing. It is not about cure of the disease. It's not disease focused. It's not just use of morphine or just counseling. So we learned that palliative care is not just end of life care. It is about improving the quality of life. And this is a good concept to understand throughout as you treat patients. What is this quality of life? When we talk about quality of life, you know, we talk about this Kalman gap. So if you see this graph, on top you see expectations and below you see the real circumstance or reality. Okay, there is a gap between patient expectations and reality. And we come across this very often. You know, they may say, I want to walk. I want to be like how I was before. I want to drive a car. And actually, maybe they are having weakness of the lower limbs. Maybe they are having cord compression. So the expectation is they want to come out of it. The reality is something different. So if the difference between the expectation and the reality is huge, then the quality of life is less. So how we can increase the quality of life is slowly improving their circumstances. Okay, you can't, the person is unable to drive a car, but can the person be taken on a wheelchair? Can they have a drive in the car? Or can they at least move around in the house using a wheelchair? How can we slowly also modify their expectations? For initially, they may be saying, I have to somehow, they're so upset that they cannot walk. Slowly, they are able to accept, at least can I be on a wheelchair? At least can I move around the house? So that is how you modify expectations, you improve circumstances and reduce this gap and thus increase the quality of life. So when we talk about person-centered care, I'm sure we are all familiar with this golden rule. Do unto others as you would like them to do unto you. You know, we have been taught, you know, if you were in that place, how would you like to be treated? You need to treat others like that. So we have often been told, how would I want to be treated? Think like that. If I were in that position, if I were dependent or all this happened to me, then what would I want? So sometimes we think, keep putting ourselves in that place. So that is a good thing to do, but that is not our standard. We move to a new standard. We stop being reliable barometers for what the patient's needs, values, and goals are. So we stop saying, I will do whatever I will do for myself, because even within their goals are different. So what we need to actually find out is what are the patient's needs. So we come to a new standard that is called the platinum rule. Platinum rule says, do unto patients as they would want done unto themselves. So this is optimal. In this way, you can optimally achieve patient-centered or person-centered care. So we need to start asking, I want to know you as a person. What more do you want to tell me about yourself? What would you like in this particular situation? Or even if the patient himself is not really able to take decisions, instead of asking, the son or daughter, what would you want us to do for your dad? You ask them, what would your dad like in a situation like this? Has your dad expressed anything around this? Okay, knowing your dad and his kind of person, what would he actually desire? And often many people would say, he is not the kind of person, he would have never wanted an NG tube. He would have never wanted to be in hospital at the end. So we can find out like that, and that helps us to understand the patient as a person and what is most appropriate, and give better person-centered care. For all this, we need to explore. Okay, what are your needs and priorities? So I remember a couple of years ago, we did a quality improvement project in our department. And along with all the assessments, one last question we would ask, at this point, what is your most important need? Okay, what do you want us to know as your most important need? Okay, for some it was, I want to be cured, I want to this pain to reduce, I want to sleep well, or I want to eat better. But for many, it was actually, I want to go back to my hometown. Here many patients come from far away, other states or even other countries. In the back of the mind, patient wants to go back home. I want to go see my children, my grandchildren. So what is it that is most important for them? Tell me what I need to know so that I can treat you better about yourself and about your family. So we saw palliative care is person-centered care. So we need to really know about the person as a person and see, remember the platinum rule, what do unto them as they would like it to be done unto themselves, so that we can give the best person-centered care. So now we will come to why palliative care is needed. Now all of you have signed up for this course. Why? What made you do that? Why everybody is talking about palliative care, and why is it actually needed for people? So coming back to that consensus-based palliative care definition, suffering, we came across this terminology, serious health-related suffering. So suffering is health-related when it is associated with any injury or illness of any kind. It is serious when it cannot be relieved without any professional intervention, and when it compromises physical, social, spiritual, or emotional functioning. So this paper in 2019, Lancet Global Health, they studied the serious health-related suffering at that point and also projected it for 2060. So here, see, those with serious health-related suffering are people who are associated with need for palliative care. In 2016, only 26 million people who died experienced serious health-related suffering. And even in that, 80% of them were from low middle-income countries, like India is a low middle-income country. And when they projected, it was estimated that 48 million people from 26, 48 million people will die with SHS, which was a 47% increase in all deaths globally. However, for low middle income countries, this was an 83% increase in the serious health related suffering, and globally, the health related suffering itself increased by 87%. So are we ready for such big projections of increase of suffering to actually reduce suffering both globally and in our own country is the question this Lancet paper is asking us. So coming to this total pain, because we're talking about suffering, we already saw it from that case scenario that I gave you, that total pain consists of physical, social, spiritual, and emotional pain. But this term, total pain, was actually coined by Dame Cicely Saunders. She is the founder of the modern hospice movement. She is from UK and defines this as a multidimensional nature of the palliative patient's pain experience, not necessarily pain, but any symptom, including the physical, psychological, social, and spiritual domains. So this need in different domains continues throughout the illness trajectory of the patient, and these needs can keep changing. We'll look at some trajectories in the following slides. So we cannot assume that what was the need when you saw the patient a month ago will be the same kind of physical, social, or emotional, spiritual needs. So it's a dynamic thing and need to be assessed every time. It varies across the trajectory. Sometimes when they start off, they want cure. Somehow I have to be cured. Then slowly you see them asking, even if cure is not possible with all this treatment, can we control? No, can we prevent the cancer from growing? When they come to that acceptance also, then they say, I have so much pain because of this. I at least want to be pain-free. I at least want to sleep well. Finally, they may move on to saying, I want to be comfortable when I die. So these needs are different at different points. And so the role of team members also can shift, change across the illness trajectory based on the need of the patient. So this is what we call the illness trajectory. This is typically for cancer. What you see on top is the illness trajectory of the patient. What you see below is for the caregiver. So I want to point out that you see 4 different trajectories for the patient and the caregiver. So in cancer, the green line, they are more or less the same situation for a long time, and then you see a steady decline before death. And that goes parallelly with the social trajectory. As long as they are physically able, they are going out, maybe some of them even do some work. Social trajectory is very parallel to the physical trajectory. The psychological and the spiritual trajectory, you can see, goes up and down at diagnosis, when they finish hospital-based care and go, when things recur, and finally during the terminal decline. So the needs are varied, and you see a similar for the caregiver also. Caregiver also has a trajectory for their well-being. So their well-being across the patient's illness trajectory, also their psychological and spiritual trajectory is very much paralleling the trajectory of the patient, very interestingly. What happens if we don't integrate palliative care right at the beginning of the diagnosis, or right at diagnosis in a patient with an incurable illness, like an advanced cancer? We may end up not providing care or that additional support of care which comes through palliative care, and allow a lot of suffering to happen, and they do not benefit early. So that is the reason why we need to integrate palliative care early in the illness. So just some hard facts and figures. According to WHO, 40 million people need palliative care each year. Like we saw in that paper also, a large proportion of them are from low middle income countries, and even globally, only 14% of those who need palliative care actually receive it. And in this graph, which is again from the same paper, the projection for pricing need, that the top column, the top one is for low middle income countries. The need is more, and you see a steep increase. There is going to be a steep increase in the need up to 2060. Then that is followed by lower middle income countries and lower upper middle income countries, and then the high income countries. And this increase is seen more in the low income and the low middle income countries. This is also a different representation of the increase in the serious health-related suffering from 2016 to 2060. In the low-income countries, it increases by 155%. And if you see in India, which is a low-middle income country, it is going to increase by 87%. So yes, there is an increase across all countries, but more with low-middle income countries and most in elderly, more than 70 years old, 183% increase. There's going to be a rise in cancer deaths and highest proportional increase in dementia. So as the proportion of people who live long is increasing, you see many people with dementia, and that is why very parallelly you see a very, very high increase in patients with dementia. But just to see this itself will give you an understanding of which are the diseases which contribute to the global burden of serious health-related suffering. On top, malignant neoplasms or cancer. Again, you see that also the number of deaths due to that is increasing. But the other closely followed by cerebrovascular disease, lung disease, dementia, liver disease, injuries, non-ischemic heart disease, renal failure. So all these diseases also contribute to high serious health-related suffering. In South Asia, it is 9.9 million. In India alone, it is 7.2 million. And in India, less than 4% of those who actually need palliative care receive it. Survey done by the economists shows that the quality of death and dying index in 2021, India is 59 out of 81 countries. We are doing quite badly in terms of the quality of death and dying. We had slightly improved from the 2015 status of being 67 upon 80. Largely because limited educational opportunities or workforce or people with capacity to provide palliative care. And this really highlights a huge need for integration of palliative care within healthcare systems. And what can actually change these numbers, change our status globally, is actually capacity building, like what is happening now, where huge number of doctors are able to understand palliative care, integrate palliative care within their own clinical setting and practice, and thus improve the quality of living, quality of death and dying. So the changing demographics again in the elderly population leading to something called multimorbidity. So there are different trajectories for cancer, for old age, for organ failures. But in multimorbidity, they are not just suffering due to one illness. So a trajectory can look something like this for the patient may have stroke, then fall. Because of old age, they also get pneumonia, dementia, then pneumonia, and so many other aspects. Look at the social problems, separation from family, friends, loneliness, being a burden, loss of control, loss of meaning, loss of purpose. So all this is just escalating and contributing to increased suffering. Okay, so we understand, you might say, now we've understood something about palliative care. We understand there is a huge need. We also understood it's not end-of-life care, but when exactly do we consider palliative care? So on your left, you see three diagrams. On top is, this was what was first proposed. You remember that first definition which I said, WHO in 2000 and in 1996 said, after after curable treatment, when there is nothing more to offer for cure, then you consider palliative care. So palliative care came in only towards the end. Then later, they said palliative care has to go alongside disease-modifying treatment or disease-directed treatment. So that is why when somebody is already diagnosed with an advanced illness, an incurable illness, please also integrate palliative care. So that little bit of that goes, but towards the end, it is more of palliative care and disease-directed treatment is not possible. But what has come now or what is proposed is something called targeted or patient-centered model, where it is a very need-based model. It is not based on diagnosis. It is not based on prognosis. It's not based on life expectancy, but right at the diagnosis, the needs are more. So at that time, more. So based on the need, palliative care comes in and patient can be seeing them at different frequencies at different points, or you can give that approach more intensively at different points, and that is targeted palliative care. We are concentrating not only on preparing for death, but actually living well, living as well as possible. I think that should be the emphasis and your understanding. What is palliative care is not you're preparing for death, but actually it is holistic approach, social care, improving their quality of life and making them live as well as possible. It is about being prepared. It is about ensuring more comfort, more safety. Okay, so planning for a car ride, but taking into consideration all measures for comfort. You're not in denial about the possible problems, but you're thinking, what if there is heat? What if the road is bumpy? What if there were some accidents, and being prepared? So that helps to keep the journey more comfortable and safe. So similarly, in a setting like this, you add supportive and palliative care measures. Okay, somebody has back pain. I will may use a wheelchair. Also add your spinal braces. There is a lot of discussion about advanced care planning, preparation for end-of-life care, which makes the whole journey much more comfortable and thought through than being unrealistic. The sad part is referral to palliative care occurs quite late, often between the first or the last 1 or 2 months of life, thus not giving the patient an opportunity to have reduced suffering prior to that. There is plenty of evidence on benefits due to early integration of palliative care from cancer, in cancer, but also now in other non-malignant advanced diseases. And the outcomes which have been shown to have benefit are, for the patient and family, there is better symptom control, fewer depressive symptoms, better quality of life, less aggressive care at end of life. They understand, they are prepared. There is no unnecessary utilization of aggressive treatments which may not help. Actually, some studies have actually shown better survival, helps patients navigate difficult disease. That journey helps in decision making, improves patient and caregiver satisfaction. Apart from that, there is a better utilization of healthcare systems and reduced costs, and there is more evidence coming on this. So to whom to consider palliative care, I think we looked at that diseases leading to global serious health-related suffering. So it is not limited only to cancer or certain groups of diseases. It is need-based. It is not diagnosis or prognosis-based. So dementia, progressive neurological conditions or lung conditions, heart conditions, kidney, liver conditions, elderly with multimorbidity, with degenerative disorders, palliative care should be considered. What I have not, there are many tools that can be used to identify if these patients have palliative care needs. There are tools for special, for ILD, there are specific tools, but there are generic tools also like the supportive and palliative care indicator tool. Independent of what condition the patient has, there are some general indicators and some clinical indicators where you can find out, okay, if this is there, this patient will benefit from a palliative care approach. So finally, who can provide palliative care? It is a business of all healthcare professionals, whether primary care or community care, who reach out to the community, or generalist palliative care, cardiologist, oncologist, who integrates these principles into their specialty. And the third level is the specialist palliative care. So a lot of management should be possible at a primary or a generalist palliative care level, like management of pain, symptoms, depression, anxiety, discussions regarding prognosis and goals of treatment. With very few palliative care specialists, you cannot think all the palliative care needs will be met by them. So when these cannot be really sorted by at a generalist level, when patient has refractory pain symptoms or complex anxiety, depression, grief, existential distress, conflicts in decision making, either in goals or end of life care decisions between the family members, between patient and family, or addressing futility issues, specialist palliative care can be called in. I understand that this may not be available in all areas of your work, but sometimes if you have people you can network with, that is a good system. So the 5 also palliative care is for all illnesses, all times, all dimensions, at all settings, and it is a global need across the countries. We talk in that definition itself that palliative care is not just about patients, it's also about carers, the families, people who are taking care of them. And just to refer to one study which showed that caregivers of patients with advanced respiratory disease, 1/3 had clinical depression. And they have practical needs, they have information needs. They also lose sometimes their role or their role within the family, or even their role or their jobs, and take up new roles. So they go through a lot of changes even as the patient goes through the illness. So all those need to be acknowledged, addressed, and supported. Just to finish with this, palliative care service models can be many. It can be as part of a outpatient consultation. It can be admission within centers for acute care, maybe symptom management or end of life care. It can be community-based domiciliary palliative care for those who can't come to the hospital, or those, some of them may be also coming to the hospital and receiving home-based care. And towards the end, some of them, if hospices are nearby, can avail hospice care or spend the last days at home or in hospital. So outpatient clinic, consultation, inpatient consultation, admissions under palliative care, community-based palliative care, hospice care. So these are the different types of care. Also to remember telehealth, which has taken off as a big wave within palliative care services also, to support, to provide palliative care interventions and support through telehealth has also been proved to be equally effective as face-to-face consultations in some studies. There is a lot of, there are many barriers to integration of palliative care, people thinking barriers from the healthcare professional side and the patient and caregiver side. The common thing between both of them is the stigma or the thought that palliative care means end of life care. Why have they referred me here? Oh, they already referred me to palliative care. So these are the wrong, are the myths that is there, which we need to work and demystify some of these thoughts, thinking that this is not compatible with disease treatment. We saw, we did see that it can be integrated. right at the start, along with disease-directed treatment. Will I destroy hope? This is a form of abandonment. How can I introduce this concept to my patient? Sometimes we are not confident in initiating these discussions, which I hope definitely will, this course will empower you to do some of these things. And sometimes palliative care is viewed as coming to what we do for that patient. Can you mute? I can hear somebody. Mic is unmuted. Yeah, so for that, remember the first patient we talked about, we started pain medicines based on the WHO ladder. Patient was admitted, got the maggots removed. I remember more than 100 maggots removed at multiple sittings, daily dressings done, taught. He was allowed to ventilate, supported by the team, and assured that we will care for him. Regular phone calls, though initially he was admitted, then he was continued to be supported at home. Family was updated about all that the patient was thinking and being afraid of. And he was reiterated of what his worth is, meaning what he has done in the past or what all he's achieved in life, and allowed being reminisced, and the family was also supported through this entire process. So we see how completely a holistic care, a person-centered care can be given even in a patient with different or difficult needs. So just to end with this quote from Dame Cicely Saunders, you matter because you are you. So each person matters. Each of their needs matter to us, and it matters up to the last moment of their life. And we will do all we can, not only to help them die peacefully, but also to live until we die. So thank you for listening. The take-home messages, I think I have reiterated about the huge need, that it is not synonymous with end-of-life care. It should be offered timely and need-based so that the patient really benefits for an entire duration of their illness. The needs are dynamic and should be assessed at different points. All the domains should be looked at. And remember the caregivers, it can be provided by the primary team in partnership with the specialist palliative care whenever. Thank you. I will stop here, and I'm happy to take any questions or any comments.
Thank you, Dr. Jenifer. That was a wonderful presentation for introduction to palliative care. Participants, do you have any questions? You can either type in the chat box, or you can unmute yourself and ask. You can raise your hand. Any doubts regarding palliative care or the definition of, you have not understood how to incorporate it in your practice? You would have come across many doubts. So we have a couple of minutes before we could start the case presentation. You are all welcome to ask doubts, or you can also write in the chat box, and we will ask the faculty. We would like participants to unmute and ask any doubts if they have.
Yeah, I can see some questions come up.
Yeah, could you please repeat 5 alls of palliative care?
Okay. The 5 alls of palliative care is for all illnesses. All illnesses, when I mean, I want to reiterate, it's not just for cancer or HIV, but all illnesses which are progressive. For all illnesses at all times. When I mean all times, is right from the diagnosis of any incurable illness. All times, all dimensions. So we talked about physical, psychological, social, spiritual, and I would like to add informational needs. So all dimensions, all settings. So whether you see the patient in the outpatient clinic or at home or in the hospital, if palliative care needs are there, it is applicable. And the needs are across all nations, though they are increased in low middle income countries.
Uh,
I hope I clarified that.
The second question, Dr. Munali, she's asking, what does end of life care constitute?
So, what I want you to take away from this class, this is the first class in your session starting today. I'm sure there will be a lot of teaching about end of life care, but what I want you to take away is palliative care is not equal to end of life care. So, end of life care covers across the NICE guidelines will tell you the last 12 months of life. So the principles of end of life care are very different from disease directed treatment or even palliative care. Your focus is completely about the goals and values and keeping the patient comfortable, removing unnecessary even medications, unnecessary investigations. So there is a lot of things around end of life care treatment, but end of life care is generally the last year of life. So end of life you can look at as a component of palliative care, but these both are not synonymous.
Dr. Shitanshu has a question, how to explain palliative care to layman or a patient's caretaker in simple terms?
Excellent question, because often in the OPD also we have people coming, why am I referred here? What is palliative care? What will you do? What is palliative treatment? So we often say, okay, fine, you're seeing the medical oncologist, they are treating your cancer. So palliative care, we look at all the issues because of the cancer, whether it is your pain or vomiting or your distress in other things, what all this cancer is doing to you, we want to reduce your suffering or your symptoms because of that. Okay, so both are important. Your cancer treatment is important, that should continue. But whatever issues are coming up because of your disease and causing suffering, causing you to find it difficult, those we want to address.
Dr. Rakesh has a question. Is there a different approach to a needy patient by general palliative care and a specialist palliative care?
Not really. So what I tried to tell was, anybody and every doctor should incorporate palliative care within their practice for patients who need it. So there is no difference going to be in your pain management and my pain management, but in refractory pain symptoms, like you may be doing up to WHO step 3 ladder, but some of them may need special medication, say maybe ketamine, or may need some pain interventions to be done, or may need infusions to be given. So when the symptoms are refractory, then it is always good to get the support of specialist palliative care. Otherwise, approach, what you do are all very similar, whether it is problems, refractory symptoms, or psychological distress which you are not able to handle, then the special additional skills or another multidisciplinary team may help in some of these issues. What's the right time? When do you start palliative care? How do you convince patient and care? Yeah, so I think I told you, the biggest barrier is the stigma. So it is important not just for you all, actually the people who are referring to say, we are sending them so that these things can be better controlled. You can actually, your pain can be better controlled. You can sleep better. What is the right time? The right time is actually at the start. If a person is having incurable illness, then at that time, their physical symptoms may be high, the psychological distress can be high. So in helping in coping, accepting diagnosis, there is a big role for palliative care. Maybe treatment has started, they are more stable now. They can be, that intense palliative care can reduce. When it recurs, then you can come in. So it's a very need-based approach. And even when if you are going to give palliative care yourself and also treat the disease, your approach or your depth it should be complete. But what I'm saying is the support, psychological support, all that can vary based on the need.
Often families use comfort care terminology in front of the patients. Does it mean the same?
Yeah, that's fine, because pallium, the word pallium means a cloak. Cloak is for comfort. So that is fine. you don't, that's fine. A supportive care,
It's
it's a supportive care in a simple word. So support, there's a small difference. Supportive care also means, in say somebody with cancer has got anemia. So blood transfusion is a supportive measure, or platelet transfusion may be a supportive measure. But don't worry about terminology. I'm saying you do what is needed. Actually, there's a lot of debate even going on saying they have to change the name from palliative care to palliative and supportive care. I think don't worry about all the, or do what is needed. It is obviously you're supporting the patient, but supportive care may have a broader meaning in terms of additional support to prevent or treat other things due to the treatment or the cancer itself.
What are the consents to be taken before admitting to palliative care homes?
Yeah, so the consent is mainly about matching the goals with what you will offer. So they have to understand about the disease, the prognosis, what can be done, what can't be done. All that should be explained before you admit. We also take consent saying, they understand it is for palliative care, that the disease is advanced, that in case of deterioration, you're not escalating to ICU care is going to be futile. So these are the things, the expectations of the patient and what is rightly to be offered should match. So that is important. Is there a difference? Management of pediatric patients with terminal care, terminal illness? Not really. All these principles apply across all ages. Remember the definition which said for individuals of all ages. So apply the principles are the same. Your management, your medications used, all that will be slightly different. Can be slightly different, not always.
Thank you, ma'am, for answering all the questions patiently. Participants, we will move to the case presentation, and if there are still any more doubts, we'll take it in the last time if we have still time.
Shri Priya, and I may leave in 5 minutes, so
okay.
If there are any questions, you can take, or you can pass it on to me, if that is okay.
We'll take a few more questions. Participant, do you have any more questions? Before we could start, we can just take a few more questions. You can unmute yourself or you can type in the chat box, and then we can proceed with the case.
I'm sure you may be able to answer most of them, but if anything, you please, I'm happy to email or whatever.
Sure, we'll do that.
Thank you very much for this opportunity, and all the very best as you start your course. Thank you.
Thank you, ma'am.
Thank you, Dr. Jenifer, for joining us. We believe that it is a busy schedule that is forcing you to leave in between, but it was really nice hearing to you, and we do hope to have you with us for more sessions in future. Thank you so much for this. Thank you so much for joining us.
Thank you so much.
Thank you, Dr. Reddy.
So, Dr. Sheila, shall I proceed with sharing the case?
Yeah, sure. Okay, so I'll start with the case presentation. This is just a model case presentation. You will be presenting in this format. If you have any doubts, you can ask at the end of the case presentation. So, 39 years old male, the diagnosis of traumatic quadriparesis with stage 3 pressure show on the sacral region and left gluteal region. Is presenting complaints where large pressure showed over the sacral region and left gluteal region since 3 weeks, pain over the left hip region and at the site of the pressure show since 2 weeks. History of presenting illness. So this gentleman had a history of fall while carrying heavy weights which was followed by neck pain and weakness of both lower limbs. He was taken to Medical College Hospital at Trivandrum and was diagnosed with traumatic quadriparesis in August 2023. He was admitted there and got treated from there and was discharged after 1 month. After 6 months, he developed a bed sore over the sacral and the left gluteal region, which was stage 3. History of pain over the left hip and the wound site for about 2 weeks. Then we'll come over the pain. Pain over the left hip region. The onset was 2 weeks. Provoking factor was minimal involvement. Palliative factor was rest or analgesics. Quality was, it was a continuous pain, an aching type of pain. There was no radiation. The pain was severe, moderate in severity. There were no temporal factors. And the pain score, which was done by numerical rating scale, was 5/10. And the pain at the site of pressure sore was, the onset was 2 weeks. Provoking factor was movement. Palliating factor was analgesics. The quality of pain was continuous throbbing type of pain. Due to this, sometimes they kept the wound open. There was no radiation. It was moderate in severity. There was no temporal factors. And the pain score was 4/10. His sleep was disturbed due to pain. His oral intake was good. And his bowel and bladder habits were normal. Examination. His vitals, temperature was 98. Pulse was 82. Respiratory rate was 13 breaths per minute. His blood pressure was 120/70 millimeters of mercury. General examination, his general condition was fair. He was afebrile, mild pallor, no pedal edema. Systemic examination, CVS, S1 and S2 were heard. There are no murmurs. Respiratory system, air entry bilateral equal. No normal vesicular breath sounds. Local examination, over the sacral region, there was a wound which was size of 7 into 6 centimeter. It was irregular in shape. It was a stage 3 pressure sore. Slough was present and there was foul smell. Left gluteal region, the size was 6 into 8 centimeter, irregular in shape. Stage 3, slough was present and there was foul smell. Treatment and significant investigations. The investigations done were hemoglobin was 10 gram, total count was 9,500 and platelets was 1.6 lakhs. His creatinine was 0.9, sodium was 138 and potassium was 4 milligram per deciliter. His pain was controlled with analgesics and wound care was given twice daily with metronidazole irrigation as there was foul smell. Proper skin care and physiotherapy was started. Treatment given, medications, tramadol 50 mg thrice a day and SOS, paracetamol 650 mg 4 times a day and SOS, bisacodyl 5 mg 2 at bedtime, syrup lactulose 15 ml HS and SOS, metaclopropamide 10 mg SOS, airbed was given. He was advised for position change every 2 hourly. Wound dressing twice daily, cleaning and dressing with debridase ointment over the slough region. For foul smell, metronidazole irrigation was given. White petroleum jelly for local application over the skin. Regular physiotherapy was advised and keep the wound closed. Psychosocial aspects. 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling who is married and living separately and not caring and helping them. He was a manual laborer and was the breadwinner of his family. Now, his mother has taken up work as a manual laborer and she is taking care of him. The main source of income is from the mother's daily wages, her pension and some of his friends. They have taken rupees 1.5 lakhs from a private finance bank for the treatment purpose. He was a Christian, devout Christian, not unable to go to church, and this made him very sad. He says to his mother, I don't think I can walk, so please don't spend money over my treatment. So his main concerns now are the pain, the pressure sore, and his financial problems. The summary is a 39-year-old male with traumatic quadriparesis and pressure sore over the sacral and the left gluteal region of stage 3 with pain over the left hip region. The discussion points. What are all the problems faced by this patient? How can we manage the problems faced by this patient? And how can we better address his psychosocial issues? Thank you. So the first point for the discussion will be what are all the problems faced by this patient? Anyone would like to add what are his problems, or you can unmute, you can chat. Please participate. Just what are all the problems faced by this patient?
So, ma'am, one of the problems, can I speak, ma'am?
Yeah.
Yeah. So this is Kinjal, pulmonologist from Jamnagar, Gujarat state. First and foremost is to address psychological issues because that will help actually being positivity. It will bring positivity towards other treatment modality also. So first is psychological counseling. That would be the very first thing which should be done along with pain management. That's my point of view.
Thank you, doctor. Yeah, we have few more things in the chat box. Quadriparesis, excellent. Pressure sore, physical pain, psychosocial issues, financial issues, difficulty in walking. Anyone would like to add more? Immobility, depression, neglect, possible malnutrition, inadequately managed pain, excellent. Okay, pain.
And concern for family members has increased as the only sole जो bread earner ही जो था वो उसमें वही है.
Yeah, right. Unable to earn. Yeah. So it is not only the physical aspect of the pain, as Dr. Jenifer had presented it, that all the aspects of the pain has to be taken, like his physical aspect, the social aspect, the financial, the psychological, the spiritual issues. Anyone can mention about the spiritual issue? Yeah, unable to go to church. Right. Excellent. Right.
He is also feeling a burden upon others.
Yeah,
as
you're
he
right.
said, why are you wasting your money on me?
Yeah, right. That's what he told his mother, that why you want to spend on me. I mean, he's feeling there's a role reversal, right? So he felt that he should take care of his mother in this age, but there's a role reversal and his mother is taking care of him. So he feels like he's a burden to his mother. Excellent, Dr. Julian. The foul smell in the wound could bring shame to him, right? So these are all the problems faced by the patient. Okay. Coming to the second discussion, how can we manage the problems faced by these patients? How can we manage? Anyone would like to answer? Counseling?
Hello, this is Dr. Deepak.
Yeah, Dr. Deepak.
Yeah, like better to have one care home where we can everything can be taken care, like food and other things, and doctor visit regular or doctor visits might help you. So and do the dressing every day. So the proper care home where the medical facility will be available. So those kind of care homes will be helpful for him. So,
yeah. There are care homes which don't charge, but there are care homes which come with charges and all. Maybe they may not afford financially. That's an excellent option. Care homes, if they don't charge, but if they charge care homes, they may not be able to afford. Not all patients can afford a care home. I mean, and not all cities have facilities like what Kerala has.
I would like to add that there are hello.
Yeah. Continue, Dr. Rahul.
Yeah, I am Dr. Rahul, neurosurgeon.
Rahul.
So this patient is of quadriplegia basically, so having multiple problems, and one solution could not be enough for this patient. So there are multiple problems. Basically, number one is as we can have, he is having wound, he is having quadriplegia, so that can be taken care of by daily dressings, which can be taught to the patient attendant basically, and regular exercises which can be taught to the patient. Second issue is, as you have rightly said, there is financial constraint also. Since he was the bread earner of the family and now his wife is earning, so he could basically, since he is having quadriplegia, he could be very well given some braces and so that he can sit up basically. And by having small shop or something that can be counseled to the patient so that he can feel good factor that he is some of use to the family basically. And regarding the psychosocial issues, he should be counseled very well. So that, because this is not the end of the life to him, basically. If he's being taken care of well, he could be living his life well.
Right, right. Excellent point, Dr. Rahul. Very nice. Yeah, so we have to first understand what bothers him the most. We have to understand his main concern, and we also have to understand about the carer. See, we should not forget about the caregiver burden, right? We may sometimes do, because it's not, the palliative care is not only about the patient, it's also about the families, the caregiver. So we have to sit with the mother, understand her issues. We have to sit with the patient, understand his issues, and we have to make him, we have to be empathetic towards them, understand what's their main concern and how useful can he be. Like we can arrange with some, Kerala has an excellent volunteer system, you know. So he has wrote that he was a devout Christian. So to begin with, we can arrange for a wheelchair with the community services, and then we can take him to a church. You know, that will make him feel good. And for the mother, we can ask some volunteers to come and, you know, sit for a few hours so that the mother can be relieved. We can tie up with some NGOs who can financially support them. So all the aspects have to be taken care of. Then
Ma'am,
pain
we can
management.
also help him to get the disability certificate and the remunerations given by the different governments.
Yeah, right. Yeah, that also we can be doing. They can get the certificate, and Kerala
And
palliative.
the bridges and all the rehabilitative equipment can be provided by the Red Cross Society. So we can contact Red Cross Society of that particular area. It can provide all these related instruments which these palliative care patient can may be helpful for them.
You're right. Excellent. We can do that. We can, Pallium India, I've been to Pallium India, and they provide food kit also to all the patients. They have an excellent this thing, because I remember few of the patients are not able to take medicines because they don't have food to cook, and Pallium India came with this idea of providing food kits also. They have this excellent rehabilitation. I think we should visit Pallium India to understand this, where, you know, the kitchen, the platforms are, you know, at low level, and where the patient can cook themselves, even the rheumatoid arthritis, even the paraplegic patients. There's one quadriplegic patient where he worked as a telephone operator. I mean, Pallium India provided him that job as a telephone operator. So we just will not take care only of the pain, the physical aspect. We will see the social aspect also, and how, so that he doesn't feel a burden to his mother. I mean, analgesics, wound care, financial, social support, counseling, excellent, psychological counseling, inclusion of family members in management, very nice, use of media to connect spiritual leaders. Yeah, we can do, he's a Christian, so we can call some father, we can request a father to come to his home, visit, and, you know, he may feel good with that. They do, Pallium India do that. Multiple approach, spiritual aspect, church pastors and elders can go and visit at home, and request the priest or any other church official of the church. Pain control, wound care. Excellent. Okay. And the last one discussion point will, how can we better address the psychosocial issues? Anyone would like to add on this?
Ma'am, it's Kinjal again. So a piece of advice to such patient is, many a times only counseling is not working.
Yeah.
So we need a good experienced psychiatric involvement, doctoral involvement, and to have medicines along with the other medicines, because only counseling may not work, as he is way too young, and he will have that passion that I'm a burden to my family. So we need medicine along with counseling.
You're right. So only counseling will not help. Definitely, we need a social worker, we need a psychotherapist, we may need a psychiatrist, because he will have a lot of psychological issues. He is unmarried, he's the only breadwinner. And we have to sit and understand first. We have to be empathetic to him. We have to sit, ask, and, you know, like, what really is bothering him. Whether he's feeling shame, whether he's feeling shy. The wound is in the sacral region, and his mother is going to take care of the wound. So maybe he's a little ashamed to show his wound to the mother. There's no one, the sibling is not helping. So we have to understand all those aspects also. Maybe shameful for him. he may not allow visitors for the same thing because the wound is foul smelling. So it is not just one doctor comes and do the dressing or the nurse comes. It's a multidisciplinary approach. So we need everyone around to take care of this patient. Antidepressant pills may help. Yeah, it may help. Definitely it may help. Need for long-term insurance. Yeah, facility-based care by NGOs, crowdfunding. Excellent. That's nice idea. Antidepressant pills. Any more suggestions? Any more thing that you would like to order? Any more questions or doubts regarding the case presentation or the class today? Anyone would like to add anything?
So I would like to ask house one question.
Yeah.
Regarding those cases. Many times we all face such kind of cases in our life, which are really young, having problem at awkward places, so-called. So can we do one thing without showing identity? Can we have like one patient counseling another patient with similar complaints? That the patient who was having such complaint in past get cured, and now the patient become a help to us in healing other patients psychologically. So that is what we are doing many times, because patient may not listen to doctor directly, but
Yeah.
if the patient will listen to the other patient. So sexual region, so another male patient who is young age who has faced may not be the similar, but really nearby problem. And then the patient visit this patient or talk with this patient that I had the problem. I trusted my doctors, I trusted all the panel, and I took all the medicines. I didn't give up, and now I'm fine. So you will be okay. Is that okay?
Yeah, that's okay. That's okay. We do that. I mean, they do that. So in Palliative India, we have a patient who was initially a patient and now she's a part of administration and she's helping with, there's a quadriplegic patient. She was initially a patient there and now she's in the management and she's helping others also. So we can do that. That's a good idea. Caregiver support groups, yeah. We can encourage him in the activity that he's interested, like reading, etc. Yeah. But probably this patient doesn't know to read. Yeah, but we can encourage him to read. We can encourage him to listen to music. He can read Bible because he is a Christian. So we have to remember that he's not a cancer patient. He's otherwise, except for his quadriparesis, which was traumatic. He has a lot of years ahead of him. So it's not like a cancer patient that he has only 2-3 years ahead of him. We have to think of long-term planning, right? Sustainable approach. Yeah, doctor, right? Vocational training, yeah. Vocational training will help because we have to take care of his finances. Maybe something like a telephone operator job or some community help or NGOs, crowdfunding, all this will help him. And we should also think of one more aspect, that he will be worried on the aspect that who will take care of him once his mother passes away, since his mother is old, right? So this thought also is going to bother him, that who will take care of him because his sibling is not ready to take care of him. So what once his mother passes away, then who is there to take that aspect, that's psychological aspect also we have to address. Motivating the family and supporting in work friend so that they give hope to the patient and bring down his burden ideas. Rehabilitation for mobility as much as possible. Good nutrition will help rapid healing. Right? See, we have to understand in India, this case, if it was in UK and the US, it would have not been mentioned in the textbook itself. Palliative for the quadriparesis patient, because there if a patient Today he's quadriplegic, then they gave him this, all those fancy wheelchairs, those electric, and he's out, he's shopping. In India, we have to think all these aspects also. The cost of the electric wheelchair, how soon can we mobilize him? Ours is still a developing country, so we have to think of all those issues. If the same patient was at the US, UK, it would have been a different for him. It would have been different. If next day he would be shopping, he would be going out, he'll be going to the movies. Their roads are friendly. They have those electric wheelchairs. The government funds everything. In India, it's slightly different. So we have to take into considerations all these aspects as far as palliative care is concerned with India. Treatment tailored according to the patient's needs, right?
Yes, one more point. I'm Dr. Rahul.
Yeah.
See, as you rightly said, outside India, it's like in England or Australia or US, there's a totally different scenario.
Yeah.
And in Indian circumstances, even the families shun these kind of patients basically. As the siblings are not able to take, they will say no. And the best example is one movie recently was there, like Chandu Champion. That also he became paraplegic and he was shunned off by the family basically. So and it is very difficult situations in these patients are actually. They are not financially sound, most of them, and not able to take care of themselves financially also. So there is a whole lot of burden on them.
Yeah.
So that basically makes them more depressed.
You're right. So a lot of barriers. We have a lot of barriers in here. In our country, there are a lot of barriers, but things are improving. Things are getting better. People are becoming more aware. Palliative care.
Yeah.
People are talking about palliative care. There are a lot of people are ready to help. Things are improving. Better than what it was decade before. Any more questions? Anyone would like to add anything? Like to comment on the presentation? Any more doubts regarding your case presentations? Or else we can wind up for today. Anyone would like to speak anything more? You can unmute yourself and ask, or you can type in chat box. I think that's it, Shreepriya. We can. That's good.
Thank you, Dr. Sheila. Thank you so much. And thank you all the participants for joining in today on time and making the session very interactive, because I could see that all of you contributed a lot to the case discussion today. And we do hope this enthusiasm lasts in the last session, because this is a mutual learning where we all learn, unlearn and relearn. So let this be a start of a great passionate career for all of you. And with the promise that we'll be meeting again in the next session with another eminent faculty and yet another important topic. This is Shreepriya along with Dr. Sheila Rathod signing off from the Tips Eco Hub. Till the next session, take care everyone. Take care. Bye-bye.
Thank you, participants. Thank you, Shreepriya. Thank you, everyone.